Welcome to the Cardiac Catheterization Laboratory at Robert Wood Johnson. Today we're going to demonstrate a cardiac catheterization via the transradial approach. Now, the transradial approach offers several advantages over the classic transfemoral and has gained increased popularity as a vascular access choice. Now, the radial artery has a much superficial course, so it is a lot easier to manage the radial artery after the procedure. And this is translated, and there's no associated major veins or nerves at the site of the radial artery, and it has a dual supply to the hand. And this is translated into a reduction in vascular access complications. So, several advantages it offers is a reduction in vascular access complications. It leads to early ambulation. It's been shown to decrease hospital costs and utilizations, as there's no needed, sheath. No one has to pull a sheath and hold manual pressure. We'll go over how to manage the radial artery after the procedure. And as far as patient selection goes, it's crucial to do what we call an Allen's test prior to the procedure. This is to demonstrate collateral circulation to the hand. So that's performed by our staff and our physicians prior to selecting a patient for transradial catheterization. Certain contraindications to going transradial include an abnormal Allen's test if patients have an AV fistula for dialysis, or a relative contraindication is if they have a vasospastic disease, i.e. Raynaud's. They're probably not an ideal candidate for the radial artery approach. So as we can tell from those contraindications, that a vast majority of patients are great candidates. So we're going to get started with the procedure. So we do have specialized equipment made for the transradial approach. We have this is the glide sheet catheter. It's got a hydrophilic coating, so it's important to soak it prior to use. So this promotes a smoother insertion and decreases the chance of getting vessel spasm. We have an 021 glide wire that we're going to use to access. And the access needle we use is a 21 gauge angiocath. Okay. Now the catheter, we also have a specialized catheter for the radial. This is called the Jackie catheter, and this is a universal catheter which can engage both the right coronary artery and the left coronary artery. And it does have a side hole on it, so you can do an LV gram as well with this catheter. So it definitely increases the speed of the procedure, that you're able to use one catheter to do all three. So we're just going to give a little bit of lidocaine over here at the access site. So as far as finding where the ideal access site location is, we go at about 2 to 3 finger breaths from the styloid process. Now, a common mistake that often operators use in the early phases, they access too close to the hand. They often may feel the pulse stronger closer to the hand, and from doing ABGs, that's a common site. However, the course closer to the hand is a little bit more tortuous, and it's a little bit smaller in caliber, so it's better to go about 2 or 3 finger breaths from the styloid process. So we're going to give a little bit of lido. You're going to feel a little pinch and a burn. Now you only want to give about 1 cc, because if you give too much lidocaine, you could obscure the pulse. So we have a nice flash over here. And now we're going to do a double wall puncture. So I went through the artery. So once I saw that flash, I advanced the needle through the back wall of the artery. And now we're going to take the needle out. And the wire, you can just hold the wire into hold the wire right there into it with the other hand close to it. So we're going to slowly pull back until we see pulsatile flow. Now we see nice pulsatile flow. Advance the wire. This is going smoothly. And now at this point, we can give a little bit more lidocaine, so the patient doesn't have discomfort when we advance the sheath. Now we're going to use a 5 French sheath to perform the diagnostic angiogram. So multiple studies have shown that sheath size does correlate with radial artery occlusion. So you want to start off with you want to use the smallest sheath as you possibly can use. Okay, and that's gone in smoothly. So once the sheath's in place, we have a cocktail that we give. So the cocktail consists of 2.5 milligrams of verapamil, 200 mics of nitro, and about 2,500 units of heparin. Now the heparin is more weight-based, it's a little bit more variable. So this is, now the radial artery, again, it's a smaller size caliber, it's more prone to spasm, so that's why we give this cocktail. Now I'm giving it through a 20 cc syringe. What I'm going to do is I'm going to pull back about 15 cc's of blood, and that decreases the pH of the cocktail. So when I administer it, it'll be less burning to the patient. Okay, you may feel a little warm feeling going in through your arm. So once that's in, now we'll flush it in. Okay, once the sheath's in, what we do is we bring the arm in, and now this simulates a femoral approach. So one of the concerns people often have in doing radial is that the radiation level may be higher, you're working out over here, but as we see, it's pretty similar to the rest of the procedure now. And, now we'll perform an intervention on that. So we've concluded the intervention. Now we're going to go over sheath management post-procedure. So I'm going to break sterility over here. Clean off the heme. So this is the TR band. So this is what we're going to use for hemostasis. I'm just going to pull back on the sheath a little bit, and the screen dot goes right over our entry site. And then we're going to put it on as we'd put on a wristwatch. Now we're going to pull back, can pull back about 15 cc's of air, and we're going to inject that. And as we're putting the rest in, we're going to pull the sheath back. So now we have about 15 cc's of air in, and now we're going to pull back slowly until we see a flash of blood. Okay, I see a little flash. I'm going to add 1 to 2 more for a total of 12 cc's of air. And the reason that we've done that is that we have patent hemostasis. You know, numerous studies have shown if you apply manual pressure, you have a higher chance of radial artery occlusion. So now we put just enough pressure to maintain hemostasis without obliterating the artery. And you feel over here, he's got a very good pulse. Okay, so this is going to stay on. After intervention, we keep it on for about 3 to 4 hours. And the big advantage to the patient right now is he doesn't have to worry about lying down flat. He could immediately ambulate depending on his sedation level, and it's a much more comfortable procedure for the patient, as well as all the benefits that we talked about before, as reduction in vascular access site complications. So that concludes our procedure.